So guys, I got some network issue, so that live stop. So guys, I got some. No problem. I started another time. So we discussed about definition of shock and types of shock and pathophysiology. Now in pathophysiology also we completed our like inflammatory response, how that septic shock can lead to um, the severe problem and life-threatening condition. So these are the things we discussed. So now stages of shock, how the stages will be. First one, initial stage. In initial stage, we can say like decreasing of oxygen delivery. Then after it will lead to lactic acidosis will start. Second one, compensatory stage. In this compensatory stage, we can see some sign and symptoms like tachycardia and vasoconstriction and blood pressure will be maintained. Next one, progressive. In progressive, we can see like hypotension. Because of hypotension, that organ will get low perfusion. Because of that thing, we can see organ dysfunction or multi-organ dysfunction. Next one, irreversible stage. In irreversible stage, like multi-organ failure totally. Because what I told before, if it's like for for less time period means that that shock will be like irreversible. If it's prolonged means we can't do anything. It will be like irreversible. So that's why if it's fourth stage, it's like irreversible. But we can say like multi organ failure or death. Okay. So these are the things most commonly we are going to see in shock. Now, pathophysiology about cardiogenic shock. How that pathophysiology means we have to divide it into myocardial infection. Because of low perfusion, we can see myocardial infection. But in this myocardial infection, we can divide into two different things. First one, diastolic dysfunction. In diastolic dysfunction, it means what? Relaxing. So here, because of some external factors that that because of low perfusion, we can see pulmonary congestion. Pulmonary congestion means that in lungs we can see some fluid. Because of the pulmonary congestion, we can see hypoxemia. That hypoxemia can lead to myocardial ischemia. Okay, these are the diastolic dysfunction. Now we are going to see the systolic dysfunction. In systolic dysfunction, we can see like systemic hypoperfusion. It can lead to systemic vasoconstriction. Then after it will lead to progressive myocardial dysfunction. Okay, so this is a step-by-step approach. Next one, hypotension. In systolic dysfunction, we can see hypotension. Because of this hypotension, reduced coronary perfusion pressure in coronary arteries. Then after it can lead to myocardial ischemia. Then after progressive myocardial dysfunction. Then after that, myocardial infection. In this myocardial infection, then after death. So this is the step-by-step shock about cardiogenic shock. Okay, so what are the clinical features we can see in shock? First one, hypertension. In hypertension, like systolic blood pressure will be like 90, less than 90 mm mercury, and our mean arterial pressure will be like less than 65 mmHg. Okay, so next one, tachycardia. That means greater than 100 beats per minute with threaded pulse. We can see uh, tachycardia. Next one, cold and clammy skin. Okay, then after peripheral cyanosis, its peripheral cyanosis is mostly oftenly present. Uh, in clammy skin means it's like except warm in early septic shock. Okay, next one we can see like tachypnea and chain strokes, breathing. Then after altered mental status, altered. Then after we can see altered mental status and urine output. In urine output like less than 30 ml per hour. Then after we can see like hyper hyperlactinemia, indicating like abnormal cellular oxygen metabolism. That lactate, if you're doing any lactate test, we can see like greater than 2 millimole per liter. Okay, so these are the clinical features about shock. Next one, how you are going to do diagnosis. How we can do diagnosis means it's very easily we can do diagnosis. That is, first one, vitals, the blood pressure, heart rate, saturation, and respiratory rate we have to check. So whenever we are checking that vitals, in that vitals we can see the change in everything. But then after ABG, if patient have any metabolic acidosis and lactate, easily we can find out in ABG. Then after CBC, complete blood count, we can easily find out like sepsis sort things, like leukocytes will increase. Like if allergic means anaphylactic means that eosinophils, basophils will increase. Okay, so these are the things based on CBC we can easily find rule out uh, the types of shocks. Okay, then after liver function test and kidney function test, we can easily rule out the end organ damage. And ECG, we can check the heart things like rate, rhythm, okay, and arrhythmia and the sinus tachycardia. And these are the things we can easily find out in ECG. Then after troponins, uh, troponin will help this like a enzyme marker. It will help to diagnose the myocardial infarction. Okay, next one, chest X-ray. Like we can do fast like fast means like final assessment of sonographic test. That means um, chest X-ray we can check any pulmonary congestion and cardiac tamponade. These are the things we can easily find out. Then after fast, in fast like we are checking the with ultrasound with sonography to any like cardiac tamponade, pulmonary effusion, and these other things is there or not. Any pulmonary embolism, these are the things. Next one, CT scan. The CT scan will help to find out the trauma or any fractures or the tamponade and these other things. And after echocardiography, it will help to find out the heart function and tamponade. Okay. So this is the step-by-step approach in diagnosis. So next, pathophysiology and are clinical manifestations of shock. First one, cardiogenic shock. This cardiogenic shock will be like reduced systolic performance. Then after it will decrease in stroke volume, and then after it will decrease in cardiac output. Then after we can see hypotension. Then after we can see like decreased in tissue and organ blood flow. Then after we can see like multi-organ systemic failure. Okay, same to same like hypovolemic shock also, and because of reduced preload. This is like step by step. In multi-organ systemic failure, we can see like GI tract, then after hemorrhage. In skeletal muscle, we can see like a hyperkalemia or lactic acidosis. In multi-organ failure, in this hypovolemic shock and cardiogenic shock means in skin we can see like cold and clammy and cyanosis and gangrene. Next one in brain, what are the things you can see? Confusion, irritability, stupor, and coma, tachypnea, and breathing and sinus strokes. Okay. Next one in kidneys, we can see like oliguria, acute tubular necrosis, acute kidney injury, hyperkalemia, and acidosis. In heart, tachycardia, ready pulse, angina, pulmonary edema, arrhythmia. So these are the things we can see in um, heart. Okay, so these are the signs and symptoms or clinical manifestations of different types of shock. Based on that shock, we can see this type of conditions. Okay, so how we can do management? So management means first of all we have to check A, B, C, D, E. This is primary assessment. Airway, ensure that patient is getting good airway or not, the saturation. And if it's like if GCH is less than 8, then we have to intubate. Next one, breathing. In this breathing, we can do like that heart rate, respiratory rate is decreased or saturation decreased. Then we can give oxygen or mechanical ventilation. Next ventilation we can do like intravenous access, fluids, and vasopressors. In drugs, we will discuss about now. I'm going to discuss each drug, dosage, side effects, how we can use everything I will discuss in management. Okay. When we are discussing about drugs, that time we can discuss that thing. E means evaluate. In evaluate, always check, monitor vitals, urine output, and lactate. Now, how we can do management? Management we can do with three main things. First one, patient monitoring. So what are the things we can do in patient monitoring means? First, we have to check, we have to monitor vitals like pulse, blood pressure, and respiration. Then after ECG, in ECG we can check like cardiac rate, rhythm, and arrhythmia. Then after ABG, in arterial blood gas, we can check pH and lactic acidosis, or maybe hypoxia. These are the things we can easily check in ABG. Then after central venous pressure, we can easily find out the how much inferior vena cava have like perfusion. Okay, these are the things we can easily find out with central venous pressure, and we can use like pulmonary capillary wedge pressure. It will help like it will help. We can use swan gauge catheter to find out the cardiogen to do management of cardiogenic shock. Okay, then after we can do like urinary catheterization for measuring the urinary pressure. Okay, so after general measures, in general measures, uh, first of all we have to take care of skin, then after airway and bowel and bladder and nutrition. How we can do skincare means if in shock patient we can say hypothermia. In hypothermia conditions, we have to give like a warm saline and these things. Then after airway, I already discussed airway in while doing primary assessment ABCDE. Then after we have to do bowel and bladder things. Then after nutrition. Then after like pain and anxiety should be like alleviated reassurance. Okay. And for some patients, we can provide a horizontal position also. In horizontal position, that legs must be elevate little up for increasing perfusion to heart. Okay. Some people will feel okay. Some people will get discomfort with this position. Then after we have to go with hypovolemic. We have to go with hypovolemic correction. So what are the things you can give? You can correct it with blood, or you can give RL means Ringer's lactate solution. Then after isotonic saline solution, a dextran, albumin, or plasma depending on the solutions. Okay. So if you're not correcting these hypovolemic conditions, what will happen? If you're not means then it will go with renal complications. In renal complications, because of what I told before while discussing about shock, if that perfusion is like less time, we can do reversible. Okay, if you're giving like fluids or cardioversion, then that time that patient will get good perfusion, then that patient will be like reversible. That shock we can do reversible. But if it's like prolonged, then it's very hard to treat, then it will go to um, irreversible cause. So what will happen if any patient got kidney related things, kidney complication, then we can see like in kidney complications, we can see like a development of acute tubular necrosis. Okay, so this is the prolonged condition. So how then after we have to correct the hypoxia conditions with face mask, nasal prongs, or intubation or mechanical ventilation. If patient have acidosis, we can give intravenous sodium bicarbonate. If patient have like cardiac arrhythmia, we can give drugs or electrical cardioversion or pacemaker, artificial pacemaker or pacing. Okay. If patient have sepsis, we can give like antibiotics or we can drainage of that sepsis. If any abscess is there, we can drainage that abscess. Okay. And we can start, if patient have septic shock means we can start low dose of corticosteroids also. Okay. Okay. So these are the management. Now, next, now we are going to discuss about drugs. In drugs, first one, vasopressors. Vasopressors and inotropic agents. In vasopressors, we can see like sympathomimetic amines. In sympathomimetic amines, we can see like it will help for before using these drugs, we have to correct the volume in patients blood perfusion and everything. Okay. So what we can do here, we have to increase myocardial contractility and heart rate and selective vasoconstriction. Okay. So what we have to do, redistribution of blood flow to vital organs like kidney, heart, brain, because these are the main organs, uh, but away skin and skeletal muscle. Okay, so because sometimes because of this sympathomimetics, sometimes that mean arterial pressure will increase. So that time what we can do, we have to manage, we have to maintain the urine output more than 30 ml per hour. Okay, and we can give like dobutamine, that is inotropic agent. So it will help to increase myocardial contractility. In cardiogenic patients, it will help to pump the blood. Okay, so now I'm going to discuss some adrenergic receptors. Where you can find the adrenergic receptors means we have alpha, beta 1 and beta 2. So these are the receptors. Alpha receptors we can see in vascular, means blood vessels. Beta 1 receptors we can see in cardia, means heart. Next one, beta 2 receptors we can see in vascular. So when you are taking that when you are taking like catecholamines or adrenaline or noradrenaline, where these things will go and how this will that site affect everything we are going to discuss now. First one, site. So in alpha adrenergic receptors, we can say like arterioles, venules, veins. The main function, main action will be like vasoconstriction. Next one, beta 1. Beta 1, where I told cardiac. In cardiac, we can see like myocardium, SA node, and AV node. Main function, main action will be like increased contraction, increased heart rate, increased atrioventricular, uh, increased atrioventricular conduction. Okay. Next one we can see like beta 2 receptor we can see in vascular, means blood vessels, where we can see that site will be like arterioles and lungs. Okay, the action will be like vasodilation and bronchodilation. So these are the main things. So now drugs of sympathomimetics. First one, dopamine. We can give dopamine in hypovolemic patients for what function? If we are giving like 3 microgram per kg per minute, then that we can see dopaminergic receptors will get activate, and we can see action will be like vasodilator action on renal, mesenteric, cerebral, and coronary vessels. Next, we can say like if we are giving that dopamine like 3 to 10 um, microgram per kg per minute, then the beta 1 receptors will get activate. We can see that increased myocardial contractility, increased heart rate, and increased cardiac output. Okay, next one, if you're giving dopamine greater than 10 microgram per kg per minute, then we can see beta 2 like alpha receptors will get activate, and we can see one function that is vasoconstriction. Okay, so next one, if you're giving dobutamine, noradrenaline, adrenaline, isoproterenol, and phenylephrine, so these are the drugs will help for reversible the shock. Okay, so some the noradrenaline is the first vasopressor of choice, best choice, and noradrenaline is the best choice and first line drug. Okay, if then also if it's not working, then after we can add some adrenaline or dopamine, or we can add some dobutamine, because it's like it will help to augment the cardiac output. Okay, so that's why this is very important. Next one, how we can manage the hemorrhagic shock, cardiogenic shock, and anaphylactic shock and distributive shock. Now we are going to discuss. First one, hypovolemic shock. What are the causes causing the hypovolemic shock means what I told: hemorrhage, burns, vomiting, and diarrhea. So these are the main things can cause hypovolemic shock. So what we can do for management, we have to bore too large intravenous, and we have to do fluid resuscitation. So we can give crystalloids like normal saline or Ringer's lactate 20 ml per kg bolus, and we have to reassess usually with 2 liters. Okay. Then after we can do blood transfusion. In blood transfusion, if patient have hemorrhagic shock, first we have to stop the bleeding, and we have to know the cause. In accidents, mostly if we have always uh, always try to get blood, then after we have to start blood transfusion. If blood transfusion, why we have to when we have to start if hemoglobin less than 7 or like active bleeding is there, then we have to start blood transfusion. So in blood transfusion, we can follow with like 1:1:1. That means plasma to platelets to red blood cells. So you can follow this 1:1:1. So based on that, you can do blood transfusion. Then after we have to stop the fluid loss with surgery, or we can control the bleeding. So always monitor the urine output like greater than equal to 0.5 ml per kg per hour. And we have to normalize the lactate also. Okay. Next one, this is the hypovolemic shock management. Now we are going to discuss about cardiogenic shock management. So what are the causes can cause cardiogenic shock means we already discussed that is myocardial infarction and anaphylactic heart failure and valvular disease or arrhythmia. So how we can do management? First one we can start with inotropes like dobutamine like 2 to 20 microgram per kg per minute. We can do intravenous infusion. Then after dopamine like 5 to 10 microgram per kg per minute. Like we have to start with moderate dose. Okay. If hypotensive like patients means we can start like norepinephrine 0.05 to 0.5 microgram per kg per minute. Okay. And we can treat causes like myocardial infarction, arrhythmia, and valve disease. For myocardial infection, we can start with aspirin plus like heparin and reperfusion, or we can do like PCI or thrombolysis. Okay, next one arrhythmia. For arrhythmia, we have to we can use anti-arrhythmetics, okay, or cardioversion. Then after valve disease, in valve disease we can see like we can do surgery. Okay, so this is the cardiogenic shock management. Next one, distributive shock. In distributive shock, yeah, septic shock and anaphylactic shock we can see. In distributive shock, that like sepsis with mean arterial pressure less than 65, despite like fluids or lactate greater than 2 liters, then we can suspect that is septic shock. So how we can do management means we can start broad spectrum antibiotics like within 1 hour, like a peptide means piperacillin tazobactam with vancomycin or without vancomycin or meropenem with picoplanin, and we can modify as per culture. Venous fluids like 30 ml per kg crystallites in first 3 hours we have to give, and vasopressors like norepinephrine 0.05 to 1 microgram per kg per minute we can give, and we can start like yeah, we can add vasopressin or epinephrine if refractory, and we can give like steroids. Steroids will be like optional. Hydrocortisone, like we can start with low doses like 200 milligram per day intravenous, especially if patient is unresponsive. Okay, always monitor mean arterial pressure greater than 65 mmHg and lactate clearance and urine output. Next, we are going to discuss about anaphylactic shock. In anaphylactic shock, the causes will be like allergy, food allergy, maybe drug allergy, maybe some bee sting or insect bite. So whenever these sort of things happening, automatically we can see anaphylactic shock. So how we can do manage the anaphylactic shock means we can start epinephrine intramuscular like 1:1000 ratio. We can like 0.3 to 0.5 milligram intravenous every 5 to 15 minutes. Like it's like in emergency conditions we can give, and we can start airway like early intubation and intravenous fluids like normal saline or ringer's lactate bolus. We can give and we can start antihistamines like diphenhydramine 25 to 50 milligram intravenous, and we can start steroids like hydrocortisone 200 milligram intravenous or methylprednisolone 125 milligram intravenous, or we can start bronchodilators like salbutamol nebulization if patient getting problem with breathing, shortness of breath, and this type of things. Next, we are going to discuss about obstructive shock. In obstructive shock, mostly it's what are the conditions can cause obstructive shock means pulmonary embolism, cardiac tamponade, tension pneumothorax. So how we can do manage, uh, how we can do management of obstructive shock means first one for pulmonary embolism, heparin, thrombolysis or alteplase 100 milligram intravenous over 2 hours, and cardiac tamponade like we can do pericardiocentesis. Next one tension pneumothorax like needle decompression or chest tube. Okay, so these are the management. Then after always when you are doing management, we have to focus on these things like lactate levels every 2 to 4 hours we have to check until normalized. And after urine output and greater than equal to 0.5 ml per kg per hour, and mean arterial pressure target will be like greater than 65 milligram. Um, and we have to always bedside echo is very important, and we can check like oxygen saturation in ICU. Okay, so these are the things very important in um, shock. Okay, so mostly we discussed everything. Yeah, so this is the shock. If you have any doubts, you can ask me in the comment section. So based on that, we will discuss. Okay, so as I promised, we discussed about shock. So what are the things we discussed? Definition, types, classification, then after pathophysiology or pathogenesis, then after management based on types, and how we can do investigation, and what are the things we have to monitor. Everything from top to bottom, everything we discussed about shock. Okay, so these are the things. Then after, now we are going to now let's take 5 minutes break. Then after we will start our mm, in general surgery perianal abscess or perirectal abscess. So this is the last topic we are going to discuss. It will take like 15 minutes. Then after we are going to end our live stream. Okay, good. So 5 minutes break. To check until normalized. After urine output, equal to 0.5 ml per kg per hour, and mean arterial pressure can 60 greater than 65 milligram. Uh, we have to always bedside echo is very important. Then So guys, just now we completed our talk, talk topic. Okay. So now we are going to discuss about in general surgery. So guys, that is perianal abscess or anorectal abscess. Okay. This topic is very important because most commonly I saw these conditions in our clinical rotation. Okay. So first of all, we have to understand what is perianal abscess. That means it's like perianal abscess, also known as anorectal abscess. Like we can see this thing, some pus, collection of pus, we can see in tissue around the anus or rectum. It's typically resulting from the infected anal gland. Okay. For example, we have one gland, okay, that is present in near to anus, anus and rectum. So there you can see one gland because of some infection. That infection is blocking that gland. Because of that gland, inside we can see some inflammatory conditions. That pus will formation, then infection. That infection leads to erythema, means redness, swelling, pain, warm sensation, and these are the things mostly we can see in perianal abscess or perirectal abscess because of collection of pus. Okay, or maybe call that is infected anal gland. Okay, so this is the main definition of peri perianal abscess or anorectal abscess. Okay, so what are the causes or why this thing happening? So what are the risk factors? First one, infection of anal glands. So most common cause, what I told, something is infection microorganisms will block the gland. Because of that thing, the pus will collect, then after it will cause infection. So this is the main cause. Second one, inflammatory disease like Crohn's disease. So this is the main condition, like increased risk of this anorectal abscess. Third one, trauma, maybe because of injury or maybe because of surgery. Okay, so around the perianal area, if they are doing any surgeries or maybe mistakenly if any injury happen, so then it can lead to abscess formation. Okay, next one, poor hygiene. If patient don't have good hygiene, it can increase the, they are very prone to get infection in that area. Next one, diabetes mellitus. Because in diabetes, we already know this thing. If any patient have diabetes, they are immunity, that very impaired immunity we can see in diabetes patients. Because of that, that infection will grow fast and it will cause this type of abscess. Okay, because for infection, glucose is the main thing to grow. Okay, so that's why diabetes is the main task are main risk factor. Next one, sexual practices like anal sex or frequent rectal examination can introduce the bacteria. Okay, so this is also this is also one of the risk factor. Next one, immune suppression. If patient like conditions like HIV, AIDS, if the patient will be have like immune suppressions, because of that immunity, they will get this anorectal abscess very common. Okay, so this is the main causes and risk factors. So we have total 5 types of perianal abscess. So now we are going to discuss these 5 types. First one, perianal abscess. Second one, ischiorectal abscess. Third one, intersphincteric abscess. Fourth one, supralevator abscess, and fifth one, perirectal abscess. So first we are going to discuss about perianal abscess. In perianal abscess, most commonly you can see this thing location in the tissue just outside the anus. That means it's outside the anus. You can see perianal abscess. Second one is rectal abscess. So this abscess you can see in exactly in ischio-rectal fossa. Where you can see ischio-rectal fossa means this is sacrum in. uh, I will try to show. I will try to connect my screen, but now I don't have that much because my laptop don't have charge. So that's why just try to understand this thing. Ischiorectal abscess. In ischiorectal abscess, we have one um, ischiofossa. Okay, ischiorectal fossa. In this ischiorectal fossa means it's like some type of depression. There you can see this type of abscess. Third one, intersphincteric abscess. In this intersphincteric abscess, between the internal and external anal sphincters. Okay, there you can see this abscess. Next one, supralevator abscess. Like it's you can see that thing above the levator muscles. Rare, but it can be dangerous. Okay. Next one, perirectal abscess. Deep abscess involving in the rectal tissues. Okay. So what are the clinical features you can see in anorectal abscess means are this pre-rectal abscess means or perirectal abscess where you can see means first one, what are the clinical features you can see means first one, pain. The pain will be like localized and sharp and constant pain in the perianal region and it's worse with movements. Okay, they can't sit, they can't get up, they can't walk. Whenever they're walking, they feel pain. Okay, so it's very hard. So first one, pain. Second one, swelling. In swelling, we can see like tenderness swelling or lump near the anus. Third one, redness and warmth, like inflammatory signs. I already discussed this thing. And then after systemic response, we can see that is fever. We can see and tenderness and palpation. We can see some tenderness and discharge. Like maybe sometimes pus may discharge from external opening or sinus and that patient will get difficulty with bowel movements like pain during defecation. You can see like painful defecation like excreting during bowel movements. Okay, so these are the clinical features. Next one, pathophy- uh, pathophysiology. In pathophysiology, what is some blockage is happening in anal gland. So what are the things can cause blockage means E. coli, okay, and maybe some anaerobic bacteria can cause this type of bacterial infections and blockage. So this infection gland becomes distended and abscess formation. If you are not treating this thing properly, then it can lead to fistula. Then after fistula, it will go to systemic infection. Okay. So that's then after it can lead to sepsis also. So that's why whenever you are seeing that abscess, always try to drain and start with like closing that area. Okay, so we have to do management. So some people we can see like sign and symptoms like local inflammation like swelling and erythema around the anus, tenderness and palpation, and systemic symptoms like fever, malaise, chills, especially in more severe infections. And sometimes if it's severe, we can see fistula formation also. It's like chronic, and if you're untreating the thing, it will lead to anal fistula may forms. Okay, so how we can do investigate? We can do physical examination. It's essential for diagnosis involving like visual inspection and digital examination also. Digital rectal examination also we can do. Next one, imaging. In imaging, we can do ultrasound. It will help to locate the abscess. And next one, MRI. This MRI will help to find out the complex abscess such as supralevator or ischiorectal abscess. Next one, CT scan we can do. Okay, to evaluate surrounding tissue involvement is there or not. Next one, fistulography. This fistulography is like if you are suspecting about fistula, then you have to do fistulography to identify the tract of the fistula. Next one, how we can do diagnosis. For clinical diagnosis, finite symptoms is enough, and inspection, physical examination is enough. Okay, for confirmatory test, MRA or ultrasound is the main test we can do. Okay, so how we can do management? We can do conservative management, like we can start with antibiotics, broad spectrum antibiotics may be prescribed in the case of extensive cellulitis or systemic infections. Next one, for pain management, analgesics like NSAID, non-steroidal anti-inflammatory drugs, or acetaminophen for pain relief. Next one, we can do surgical management, that is like incision and drainage. Uh, Most common surgical procedure for drainage the abscess and abscess incised under local general anesthesia, and the pus is drained. Okay, so we can use one technique, that is abscess. We have to most dependent part of the um, abscess cavity, and the pus we can drain, and we have to left the open, and easily that if that pus is generating more, then it will drain by one. Okay, so if you're suspecting fistula in MRI, is showing like in fistulography, it's showing like fistula is 100% confirmation. Then after we can do fistula surgery to, if that fistula, we can do fistula surgery like such as like fistulotomy or fistulectomy. Complex you can see like includes like internal and external anal sphincters. Next one, third one, levator ani muscles. This levator ani muscle, we can see like it provides support to the anal canal and is important in high abscess. Next one, we can see like ischiorectal fossa, like located in laterally to the anus, an important area for abscess drainage. Okay, so we can see some complications with this anorectal abscess or perirectal abscess. What are the complications means? Um, Sepsis, fistula, and incontinence and recurrent abscess. So these are the things is the most common complications. Okay. So next we are going to see the differential diagnosis, because in general surgery I never expect this type of this many differential diagnosis. The doctor will ask you, just tell me the 10 differential diagnosis. For telling 5 differential diagnosis, we will get problem. But the doctor will ask 10 differential diagnosis. So that's why always whenever you are doing general surgery, try to focus on these things. In differential diagnosis, first one, hemorrhoids, anal fissure, skin abscess, and proctitis means inflammation in the rectal lining or rectal cancer. So these are the main differential diagnosis. Okay. So we discussed about perianal abscess and anorectal abscess or anorectal abscess. Okay. So today in this live stream we discussed about shock types, definition, and what are the management we can do, drugs, dosage, everything we talk from top to bottom, from basic to clinicals, everything we discussed about shock. Okay. If you have any doubts, you can drop one message in comment section. Based on that, I will cover that topic. Okay. So next one we discussed in general surgery, that is perianal abscess or anorectal abscess. These are the topic we discussed. Okay. So in this today topics, so actually I'm doing live stream for 3 weeks. That is totally about general surgery. Okay, because I'm going to write my clinical examination in 3 weeks. So that's why I started 3 weeks general surgery. So here in first week, day one, we discussed about wound healing, inflammation, suture, and sterilization, and we discussed some about basic surgical asepsis and wound care. So today is day first week, day two. So what topic we discussed today? Shock types, clinical features, management, and some like how we can do management of and everything. So tomorrow will be day three. In first week, day three. So tomorrow we are going to discuss about fluid and electrolyte balance and blood transfusion. And in live discussion, we are going to discuss about fluids in surgery. What are the fluids when we have to give, like normal saline, Ringer's lactate, dextrose, and some like albumin, okay, plasma, and everything, every fluids, how we can give, how much dosage we can give, everything we are going to discuss tomorrow. Okay. So if you have any doubts, you can ask me in comment section. If you didn't subscribe my channel, try to share this channel. And if you are, I hope if this live stream is helping you, if it's like beneficial for you, just like, share, and subscribe. Okay. So we will meet in our next means tomorrow, same time, live stream. Okay. So take care. Bye bye. Have a nice day.